Senator Markley, Representative Ritter, and Srinivasan, and distinguished members of the Public Health Committee, my name is Carolyn Treese, and I'm the Executive Director of the Permanent Commission on the Status of Women. Thank you for the opportunity today to provide testimony on House Bill 5211, an act concerning certificates of need, and I'm going to try to speak really fast. The PCSW has a long history of following and in some cases intervening in certificate of need proceedings in cases where we, along with partner organizations, believed that women's access to reproductive health services was threatened. Most recently, the PCSW and our partners have been watching the rapidly evolving and changing hospital landscape in Connecticut with varying levels of interest and concern. I don't need to tell any of you, as you've already heard a lot about, that the state is experiencing an unprecedented time of volatility characterized by hospital mergers, affiliations, and acquisitions, often of smaller community hospitals with large hospital systems. In some cases, those systems are in-state and nonprofit. In other cases, they are out-of-state systems that are nonprofit or for-profit. This new reality is driven by the need of small community hospitals to partner with larger systems in order to benefit from economies of scale and other efficiencies, as well as gain access to much-needed capital. Often, however, these partnerships, as we've heard, involve more than just the consolidation of back-office functions. They're accompanied by the restructuring of services across the different facilities within the larger system, or in some cases, the elimination of service lines altogether. PCSW appreciates that Connecticut's communities may in fact benefit from some of the infrastructural and technological investments as well as quality enhancements that may result from those changes. And Representative Sayers alluded to some of that in her comments. But we also believe that women's access to essential health services, such as gynecological, prenatal, and obstetrical care, may be compromised under the current law without proper oversight. The fact of the matter is that the CON regulatory scheme was not designed for the current marketplace. And we thank the Public Health Committee for recognizing this and for attempting to address a gap that exists in the current CON law. The current statute requires a certificate of need when a healthcare facility proposes to terminate services, but it does not address situations where services may be reduced. By way of example, a large system that owns several smaller hospitals may decide, for instance, to consolidate all maternity care at one of its locations. This could pose a substantial hardship for women, particularly low-income women with limited access to transportation in certain geographic regions of the state. Such a change could effectively result in the termination of that service for women in that part of the state due to a lack of access. But a CON would not necessarily be required in that case under the current statute. We feel that such a change in service delivery should undergo CON review, and the community should have an opportunity to weigh in through a public hearing process. And you heard about the problems that were encountered in Wyndham. Thus, the PCSW supports legislation that will ensure that women at the greatest risk of losing access to comprehensive reproductive services, such as those in low-income and more isolated communities, are more fully considered in the CON process, and legislation, hopefully, that will ensure that access to core reproductive health services, which is something, Representative Ritter, that you asked about, will not be eroded or compromised in the absence of some regulatory oversight. We'd be grateful for the opportunity to be involved in further discussions about the specific language of this bill so that we can ensure that the language covers the many scenarios that may arise in this ever-changing landscape. Thank you very much for your thoughtful consideration of this proposal, and I'm happy to answer questions, although I can't imagine you have more, given the rigorous questioning of the representative and the senator earlier.
We might surprise you.
Thank you, Mr. Chair. Thank you, Carolyn, for your testimony this afternoon. Just a quick question. In the previous discussions, and we had quite an extensive discussion on the subject matter, as you alluded to, we had talked about thresholds. You know, we had talked about 50% threshold, and then 25% was mentioned. And I'm interested in knowing from you that, do you believe in thresholds, A, and B, if you do so, what do you think should be the threshold as far as reduction of services are concerned?
Thank you for that question. And actually, that section that you refer to, it's in section 1, sub 17. One of the questions that I actually had was, what was the significance of that 50% threshold, and or 25, or whatever we're talking about. And since it wasn't a bill that I drafted, I didn't know sort of what the reasoning was behind that threshold. And in fact, I think sometimes thresholds can cut the other way, because there can be situations where, for instance, you might have a certain procedure or service line that could be cut, but because of the amount that it is done in the hospital, it doesn't ever reach that threshold of 25% of direct care staff hours. So I'm not sure, I certainly am not against a threshold, but I think if there is to be one in the bill, we really have to understand what is the rationale for that threshold, and does it really get at a lot of the different scenarios that could come up, and ones that are, particularly important for women's health care.
Thank you.
So
Thank
I'm
you,
not
Mr.
sure I
Chair.
answered your question that well, but I'm not sure what the right answer is right now.
Thank you, and that's the answer I wanted. So